Hello everyone, welcome back to our class. Today we will continue to talk about pain management. Last time we introduced the definition of pain, its modifying factors, and the assessment. This time we are going to discuss how to manage pain. Our objectives for today are: describe the World Health Organization's three-step approach of analgesic ladder. Describe pharmacology interventions of pain. Two methods are used to control pain: non-pharmacological methods and pharmacologic pain management. Let's introduce the non-pharmacologic methods first. Non-pharmacologic pain management consists of a variety of physical, cognitive, behavioral, and lifestyle pain control strategies that target the body, mind, spirit, and social interactions. Physical treatment modalities include continuous stimulation, ice or heat, therapeutic exercises, transcutaneous electrical nerve stimulation, and acupuncture. Mind-body interventions include distracting activities, relaxation techniques, imagery, meditation, and hypnosis. Lifestyle management approaches include symptom monitoring, stress management, exercise, nutrition, pacing activities, and disability management. After discussing non-pharmacological treatment, let's go through drug management now. This involves the use of opioids, non-opioids such as non-steroidal anti-inflammatory drugs, and cholinergic drugs. The WHO provided a logical three-step approach, also known as an analgesic ladder. The three-step ladder focuses on aligning the proper analgesic with the intensity of pain. Do you remember the numeric rating scale used to assess the intensity of pain? Yes, 0 is no pain. A range of 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe pain. But how do we treat different stages of pain according to the WHO's three-step approach? For patients with mild pain, Step 1, drugs of the analgesic ladder. Non-opioid analgesics with or without a analgesic is a reasonable starting point. If the patient has mild pain that persists or increases despite using full doses of Step 1 medications, or if the pain is moderate, then a Step 2 routine is appropriate. At the second step, an opioid for moderate pain. Representative medicines are codeine and tramadol, or a combination of opioid and non-opioid drugs are provided with or without cholinergic medications. If the intensity of pain increases, then a Step 3 schedule is medically indicated. At the third step, an opioid for severe pain is titrated in around-the-clock scheduled doses until the pain is relieved. The representative medicine in these steps are morphine and fentanyl. Pain medicine can be given by the following routes: oral, transdermal, transmucosal, rectal, intravenous, subcutaneous, intraspinal, and intramuscular. Oral administration of opioids remains the preferred route because of the convenience and lower costs. Transdermal drug therapy delivers a relatively stable plasma drug level and is non-invasive. The representative drug, fentanyl, provides drug delivery for up to 72 hours. Nurses must inform patients not to use fentanyl patch when they have a fever, because heat will increase absorption. The transmucosal route is helpful for breakthrough pain because the oral mucosa is well vascularized, which facilitates rapid absorption. The rectal route is particularly useful for patients who have difficulty swallowing or nausea and vomiting. Intravenous administration route provides the most rapid onset for pain relief. However, the adverse effects such as respiratory depression also occurs quickly. So we need to pay more attention to the side effects when we use the intravenous route. Subcutaneous catheters and infusion pumps provide continuous subcutaneous infusion of opioids. CSCI is particularly helpful for patients whose pain is poorly controlled by oral medications. The intraspinal injection delivers analgesics to the opioid receptors in the dorsal horn of the spinal cord, thereby blocking the conduction of pain. The intramuscular route should be abandoned because of the disadvantages. When we use pain medicine, we need to pay attention to the principles of the three-step analgesic ladder. There are 5 principles. We choose oral administration first. We need to use pain medicine according to the analgesic ladder. Medication should be delivered on time. Prescribe individualized dosage for different patients. Monitor the side effects. Make sure the patient's pain is well controlled and the side effect is minimal. What are the side effects of analgesics? Side effects of opioids typically include constipation, nausea and vomiting, sedation, respiratory depression, urinary irritation, blurred vision, and sexual dysfunction. Constipation is an almost universal adverse effect of opioids. We should ask patients to increase fruit intake, fresh fruit and vegetables, and if possible, increase daily exercise. If these methods are not effective, we can provide laxatives. Nausea and vomiting usually occur during the first few days after the initial administration. We should tell the patients this reaction will disappear after several days. If they turn out to be intolerant of this effect, provide an antiemetic or change the dose or analgesics as indicated. Sedation also will disappear a few days after taking the medication. Another side effect is respiratory depression. We need to monitor the patient's breathing every minute, especially for those after surgery. We can teach patients to take deep breaths regularly. The rate of urinary retention with opioid use is low. How do we evaluate the effect of pain control? We have a 3-3-3 goal. We should control the intensity of pain to below NRS of 3. Breakthrough pain occurs less than 3 times in 24 hours. Patients would use short-acting analgesics less than 3 times in a day. We need to control pain as soon as possible in order to improve the patient's quality of life. The next part is education. We should educate the patients within 8 hours after admission. We need to correct the patient's misconception about pain, tell them about the physical and physiological effects of pain, how to express the pain correctly, teach them some non-pharmacological methods to relieve pain, discuss the side effects of analgesics, and so on. And the last part is follow-up. we need to implement return calls via telephone or conduct follow-up on WeChat or on the internet once a week. Ask the patient whether he or she is taking medicine regularly, whether there is any side effect, and whether the pain lessens after discharge. Do you remember the patient we discussed during the last class? A woman with colon cancer who complained of interrupted sleep at night due to pain. Can you tell me which step of analgesia is needed? Yes, we can choose the second step, an opioid codeine or tramadol, or a combination of opioid and non-opioid medicine. Okay, that's all for this session. These are my references. Bye-bye.